So we are very fortunate to have Dr. Elizabeth Ollen present today. Dr. Ollen is a postdoctoral scholar at the UCLA Semel Institute. I know that many of you know her, but let me read a little bit more about her. She specializes in treating youth and families who've experienced trauma and other stressors, with an emphasis on providing affirming care for LGBTQ adolescents. Dr. Ollen leads program development, provides direct clinical services, and supervises advanced trainees for the UCLA's Empower program, which offers LGBTQ youth and their families sensitive and affirming comprehensive mental health care. She also provides clinical services at the UCLA Ties for Families, where she focuses on same-sex couples fostering and or adopting, as well as LGBTQ foster youth. Dr. Ollen's research interests include family and relationship dynamics among LGBTQ populations. She's currently involved in research and development of therapeutic interventions to foster resiliency among LGBTQ adolescents and their parents. Dr. Ollen earned her PhD in clinical psychology from Clark University and completed her pre-doctoral psychology internship here with us at UCLA Semel Institute in the STAR track. She holds a master's degree in human development from Harvard University. So thank you so much for joining us. We're really honored to have you here.
Super, thank you for the lovely introduction. Okay, so good morning. Thanks for coming and bearing with us with all of our technological issues. I'm excited today to talk to you about supporting trans and gender diverse youth from a gender affirmative model. So I just want to give a quick overview. So I'm going to cover a lot today. And so I just want to give you a little bit of a roadmap of where we'll go. So I'm going to start out with just a review of gender identity, talking about the development of gender identity in children, theories that we have about why gender identity develops, and barriers to healthy gender identity development. I'm going to talk a little bit about the health disparities that we know exist in this population, as well as explanations for why those health disparities exist. And then also our current issues in the field about provider training. And then I'll go on to spend time talking about the existing guidelines that we have, and I'll spend the most time talking about the gender affirmative model, including the basic principles and application to clinical work. Here are the learning objectives. I'm going to skip this because I think we're already a little short on time, and you probably know what they are already. So first I'm going to start out with the gender unicorn. This is a pretty neat little graphic that helps explain some concepts that usually get conflated. So we have gender identity, which is different from gender expression, which is different than sex assigned at birth, and then who somebody is physically attracted to or emotionally attracted to is typically in the category of sexual orientation. I think these concepts usually get conflated because we sort of have our acronym of LGBTQ kind of all lumped together, where like the first couple letters we're referring to sexual orientation, whereas with the T, we're usually referring to gender identity. So gender expression is just very simply your outward expression of gender. So this might be through how you dress or other physical markers like your hairstyle. And gender identity is how you perceive yourself or how you describe yourself. And some people might say that this is what's between your ears, since it is very much an internal process of how you identify yourself, and it's not visible to other people. Gender expression is what would be visible to other people. So sex is sometimes referred to as what's between your legs, but it's actually more than just external genitalia. It's actually our chromosomes, our sex hormones, and then both internal and external genitalia, the latter, which is typically used to assign sex at birth. So when we're talking about transgender versus cisgender identities, somebody who identifies as cisgender is simply someone whose gender identity aligns with their sex assigned at birth, and a transgender identity would be when your gender identity differs from your sex assigned at birth. So here's a really cliche rainbow umbrella. But I do think gender identity is truly a spectrum, and so I think it is a good representation. One of the big takeaway points that I hope you get from today is that gender can be dynamic and fluid, and it's not necessarily always static and binary. And we have just this constant evolving terminology. So even those of us who specialize in working with trans or gender diverse youth have a hard time keeping up. These are constantly changing. This is just like an example of a couple that I threw up here. There's a lot of different terminology that is available to us today. And it's important to remember that this language is not universally agreed upon, both within these communities and then also among professionals. So the language that I choose to use today is not necessarily going to fit with what everybody would necessarily use. So gender nonconforming, I think, is the most commonly used terminology in the academic literature. You'll also see gender variant. I have already seen a shift away from these terms. I think that people are starting to recognize more kind of like the negative connotation that we have with being other than normal or deviant in some way. And so gender expansive, gender diverse, I like gender creative. These are all the terms that we're sort of moving towards at this point. And I purposely included both male and female under here, just to point out that a lot of individuals, even if they sort of by criteria meet the definition of like a transgender identity, they might not identify as a trans male or a trans female. They might just identify as male or female. So before I move on to talk about gender identity development and how children get to a place where they're using one of these identities, I just want to take a couple of minutes to make a few comments on our diagnostic criteria. So the current DSM-5 diagnostic criteria for children require at least 6 of these 8 criteria to be present for at least 6 months, but these symptoms must be associated with significant distress. And this was an update from DSM-4, where we had gender identity disorder as our diagnosis, and offered some improvement in language and criteria. Because gender identity disorder is really, I think we moved away from that in part because it implies that there is something disordered about your identity. But there's still ongoing controversy about whether or not a diagnosis should really exist at all. And this current diagnosis is still pathologizing certain gender identities. And this is particularly important if we're moving towards a conceptualization of human gender identity as being something that is a natural variation of human gender. So as of 2013, gender nonconformity in and of itself is no longer sufficient to meet criteria. So if a child has a creative or an expansive gender identity and expression, they don't automatically meet criteria for gender dysphoria. And this was different from gender identity disorder in DSM-4, when if you had a child who had any sort of gender nonconforming behaviors, they were categorized as having gender identity disorder. And so we went from a diagnosis that pathologizes simply being gender diverse in some way to a diagnosis that pathologizes being gender diverse if you're distressed about it. So, and I think we all know that we live in a culture that really restricts and constricts and polices gender in a way that it's almost expected that if you have a gender diverse identity that you'll probably experience distress in some way. So this narrative of changing diagnostic criteria is a familiar one. We saw a similar change when the field started to move towards recognizing same-sex attraction as being a normal, natural variation of human behavior. Does anyone know when homosexuality was removed from the DSM? Close. So most people say it's 1973. And that's when homosexuality as a diagnosis was removed. But it was actually just reclassified as sexual orientation disturbance, which is just basically a repackaging of pathology. So it went from having same-sex attraction, you meet criteria for this diagnosis, to same-sex attraction and you're distressed about it, you still meet criteria for this diagnosis. So this was actually on the books. Pathologizing same-sex attraction was actually on the books, quote unquote, for the DSM until 1987, when it was completely removed. And so I do imagine that at some point in the future, we'll be moving away from a diagnosis entirely. But for now, we have gender dysphoria. Okay, so back to gender identity. So when do children start to understand gender? There's some studies that indicate that as early as infancy, infants can tell the difference between male and female voices and male and female faces. But starting around 18 months is really the earliest we can see some children starting to grasp concepts about gender. So around 18 months around 2 years old, rather, children can start to understand the physical, usually anatomical differences between boys and girls. And before the age of 3, they're usually identifying themselves and others as boys and girls. And by the age of 4 or 5, we're really seeing that children tend to have a stronger sense of their personal gender identity. And all the while, we're also developing our sense of gender roles at this time. So what boys are supposed to do and what girls are supposed to do, in air quotes. And so since gender identity clearly develops pretty early, child and adolescent providers can't avoid the likelihood that they're going to see some type of gender expansive youth in their office at some point. So more on this later, but for now I'll just say that there tends to be two age groups that present to mental health providers, either in specialty clinics or in general outpatient clinics. And I think it's important to highlight that there isn't necessarily one right way to develop a healthy gender identity, and there are a lot of pathways to developing an authentic sense of yourself. Some pathways I think are seemingly easier for adults to understand, such as the early presenters. So these are usually pretty young kids who are showing up with a pretty similar story of always knowing that their gender was different from what others told them. This is on the same timeline that I just talked about as cisgender peers of like having a pretty good sense of your gender identity by the time you're 4 or 5 years old. But not all children develop gender identity on this kind of early timeline for a couple of reasons that I'll talk about in a few minutes. But the second group of kids who show up are sort of right around puberty or right after puberty. And I think people tend to struggle to understand these kids because in the media we have all these portrayals of young little kids, you know, talking about their gender identity, and those are the ones who have persisted and that must have a quote unquote like authentic transgender identity. But since male and female bodies look pretty similar before puberty, it's not surprising that once puberty hits and they suddenly see all these changes, that gender dysphoria cannot set in until puberty. So there are a handful of theories that address kind of how and to some extent why gender develops. But in general, as a field, we don't have a great understanding of why gender develops in the way that it does. So we have a biological theory of gender identity, which is pretty strong, that's drawn from studies of evolution and biology and genetics. And basically it asserts that our physical and behavioral sex differences are due to things like chromosomes, sex hormones, and brain development. And there's a handful of recent studies that really support this. There's some interesting studies on exposure and absorption of prenatal and postnatal hormones that show that they play a role in gender identity and that certain hormones are correlated with certain gender identities later in life. Twin studies have found a pretty high concordance rate for trans identities, higher among identical rather than fraternal twins, suggesting at least some biological component. And from recent brain imaging studies, we also know, actually fairly recent from the last couple of months, and there's been some controversy around whether or not there is a male brain and a female brain, but that the brains of transgender women look more similar to cisgender women, and the same for trans and cisgender men. But so as most things that have to do with the human condition, really one theory doesn't necessarily fully explain anything. We also have like a socialization theory, and this just basically suggests that, at least in part, that our gender identity is guided by the differential treatment of boys and girls. So for example, Bandora's learning theory posits that behavior, including gendered behavior, is learned from the social environment. So children pattern their gender behavior after models, who are adults, and then such gender behavior is reinforced by those adults, most of whom have pretty prescribed ideas about what gender is and should be. There's also a cognitive theory suggesting that as children, we acquire a gender schema. This includes internalizing knowledge about gender stereotypes and norms, and how children think and behave. So the most likely theory, when we usually have these nature-nurture arguments, is that, and this particular one comes from a gender-affirming perspective, is that gender identity is neither essentialist, so things in nature are given, nor environmentalist, meaning that all that we know about gender is socially constructed, but rather transactionalist, so that we are a confluence of factors of biology and environment and culture and context. So there's presumably a lot of factors that contribute to gender identity development, but the literature does identify a few explicit reasons that can hinder healthy gender identity development, the first being lack of safety. So basic survival instincts in children are going to have them hide their true authentic gender in situations where they don't feel loved and supported and safe. Adults also at times are not really good at recognizing the differences in threat or danger levels between gender identity explored in private, usually at home, with those that the child trusts versus in more public settings. I'll talk more about this later, but there's this big ongoing debate and lack of consensus among professionals about how to best address trans youth. We have a pretty big spectrum of opinions, and it ranges from people who say that offering affirmative care to youth is akin to child abuse, and then people on the other end of that spectrum who would say it's actually life-saving treatment. We also know that even with support from families of origin, that lack of support from school and religious communities in the larger cultural context is enough to derail healthy gender development. And then finally, some people really see an affirming approach of the gender affirming model as disruptive to the way things are in society, and really this tacit devotion that we have to dominant ideas of gender. So when we think about gender exploration, one of the big questions that's usually raised is around whether young children really know their gender when we don't necessarily trust them to choose what they want for dinner. So if we stop and think about this question and really read between the lines, this question is typically asked by people who are trying to poke holes in the rationale for providing affirmative treatment for children. I don't think anyone's ever asked this question about a cisgender child. So there are a couple of studies using retrospective data, which obviously has its limits, but indicating that an overwhelming majority of transgender adults knew by the age of 12 what their gender identity was, with the average age being about 5.5 years old. So due to some of the early research that came out of a gender clinic in Amsterdam on the trajectory of transgender identities in children, the initial approach to treating trans children was very conservative and subsequently a not particularly affirming one. So even though these clinicians from the Netherlands were on the forefront of medically treating adolescents, as they were actually the first group who were offering hormones to block puberty, but they were trying to follow up they were trying to figure out what this trajectory of gender identity looked like in children, and they were basically just using pretty poor methodology that I'll talk about in a few minutes. So this group published a couple of articles between 2008 and 2011, and the researchers claimed that the majority of children that showed up to their gender clinic, about 70 to 80%, that qualified as what they were calling desisters. So this basically meant that by adolescence, they were no longer identifying as trans or gender variant in some way. So the group of persisters would go on to persist in their transgender identity and become good candidates for puberty blockers and cross-sex hormones. But the researchers concluded that without a true litmus test of sorts, really having no solid predictive factors to sort out the persisters from the desisters in early childhood, the conclusion was really a wait-and-see approach, to wait and see if the identity persisted into adolescence at that point to proceed with affirming steps could be taken at that point. I'm not going to read this whole thing here, but basically, right about the same time, the largest trans professional organization, which is WPATH, the World Professional Association for Transgender Health, wrote the first standards of care that addressed children in any way. And based on these data that were pretty shoddy to begin with, they recommended a very, very cautionary approach, and even cited this research suggesting that parents and providers should make sure that they consider kind of the pros and cons of a transition or any sort of affirmative steps. Relevant in this respect are the previously described relatively low persistence rates of childhood gender dysphoria. A change back to original gender role can be highly distressing and even result in postponement of the second social transition on the child's part. So pretty cautionary language that they were giving here. But a group of researchers from the United States, including the ones who've developed the gender affirmative model that I'll talk about today, have called out some of the methodological issues with the Dutch studies. So the first issue is that researchers lacked good specificity when they're differentiating between children who are exploring gender identity versus those who are exploring gender expression, or in other words, apples and oranges. Essentially, apples and oranges had been lumped together, and this really necessarily lost the ability to identify the nuances between these two groups. So the second issue being that children who were lost to follow-up were put in the desisters group. So they had no hard evidence about what their identity was when they reached adolescence, but since they didn't return to this gender clinic as adolescents, they put them in the desisters group, making that number of desisters go quite high. So in 2013, the same Dutch group released a re-evaluation of their persister-desister data and basically found that there were differences between apples and oranges when it came to diagnosis, gender nonconforming behavior, gender fluidity, and then also adolescent sexual orientation. So in other words, after reanalyzing these data, they realized that they were indeed actually able to, with some reliability, start to tell the difference between apples and oranges. And so with these and other emerging data, we're starting to identify a cluster of behaviors and feelings that can actually determine who the little apples might be. And so this is like really to separate the children who are ripe for a social transition from the children who are exploring gender expressions, but not necessarily gender identities. So this is kind of like who the apples are really we think of as our youngest transgender people, or the persisters. And these children are really insistent, persistent, and consistent in their identities. They tend to express body dysphoria. They tend not to have, that is a typo. They do, so the third bullet point is supposed to be the opposite of that. So they tend to have strong feelings about their sex assigned at birth, and that their gender exploration is not just in play, but it's more serious work, if you will. They tend to use language like I am a boy or girl or other, versus the D sisters are our oranges, who actually are likely to tend to grow up to be our LGBTQ cisgender adults. These tend to be our gender diverse children who are not necessarily transgender. They tend to have some gender nonconforming behaviors, yet they don't particularly have strong feelings about their sex assigned at birth, in a negative way at least. Their play tends to be in fantasy or ruminations about being of another sex or gender, but not necessarily like across the board. And their verbalizations tend to be more along the lines of, I wish I was a boy or girl. So you can sort of start to see some like qualitative differences here. And we can't really say anything about the difference between apples and oranges with 100% certainty. Sometimes little oranges can confuse us because they might just be low-key apples that are just not as consistent and persistent and insistent about their identities. But really the oranges, regardless, the oranges can still benefit from an affirmative approach. So I'm gonna come back to apples and oranges later, so sort of hold that thought for now. But basically in the last couple of years, we've seen a really big increase in the visibility of these little apples and oranges, including steadily increasing awareness both within mental health professionals as well as just in the general population. We've also seen major media outlets increasingly feature transgender children and their families on TV. But kind of in the background, we still have this simmering debate about like how to treat trans and gender diverse children. I don't know if you recognize much of this. The two pictures all the way on the left, the top one is from Transparent, the bottom one's from Modern Family. They were the these are the first two trans actors, the little girl all the way on the left and the little boy all the way on the left, were the first trans actors to be portrayed on major TV. They both played trans roles but they identify as trans in real life as well. I Am Jazz is she's a really sweet, charismatic little girl who transitioned when she was quite young, and TLC picked it up, and it's this reality show that's quite entertaining if you've never seen it. The top right is from The Fosters. They actually have a couple of trans characters. Erin here on the right is the trans character. National Geographic last year actually did a really cool cover story about gender, which I have a copy of up here if people want to take a look at. And then also we see kind of like the children of celebrities being more gender diverse. This is Shiloh Jolie Pitt and Brad and Angelina, who some people speculate is trans. I don't think they've said one way or the other that I know of, but that is a pretty gender diverse expression. And then this is Jaden Smith, Will Smith's son, who identifies as male, but does a lot of kind of gender bending in his work. He's been featured in either, I think, Dior or Louis Vuitton, like wearing a dress or a skirt, and he tends to like wearing dresses or skirts and still identifies as male. So I think that's a good example of kind of how gender expression can play out. So with this greater visibility, we're also seeing more trans youth and gender diverse youth in clinical settings, both in general clinical settings and also in subspecialty clinical settings. And the last couple of years, there's been this increase, I think, has really illustrated the need for more training and for more knowledge around how to treat these kids. It really leaves us facing this question of like, how do we identify what the best practice is? What are the best practices to treat these children? So trans and gender diverse youth are really presenting to clinical settings due to higher rates of mental health issues compared to their cisgender peers, pretty much across the board. Pretty much any outcome you can think of, it tends to be worse. Recent data from the CDC and other national surveys are also reflecting these trends. And this probably isn't new information to a lot of you in here. Health disparities really do exist across the board for trans and gender diverse folks across the lifespan. This is not unique to children. But really, I think the important thing to highlight here is that a trans or gender diverse identity in and of itself is not the cause of mental health issues, but rather research has shown that this vulnerability is more likely due to the societal discrimination and rejection and oppression that these populations experience. So what we do know is that being affirmed and supported, particularly by family of origin, has a tremendously positive impact on health outcomes. And there's actually some studies that show that transgender youth who are supported in their identities by their families actually have similar depression and anxiety rates as their cisgender peers, which is quite remarkable given all the additional adversity that they face. So one useful framework to explain these disparities is from a minority stress lens, which is the basic premise just contends that stress stemming from the social environment can lead to psychological distress and also poor physical health and other maladaptive coping. So this was initially developed by Elon Mayer to apply to sexual minorities, and then was later adapted by Michael Hendricks and his colleagues for work with gender diverse folks. But the basic tenets are the same, which is that minority stressors are unique, they're chronic, and they're socially embedded. So it's broken down into both proximal and distal stressors, the proximal stressors being more internal, such as expectation of rejection or internalized homophobia, and distal stressors being more external, experiences of prejudice and discrimination, or transphobia, or cissexism. And this model is really supported by a pretty large body of literature that really helps the efforts to destigmatize diverse identities because it really clarifies that it's not gender identity in and of itself or sexual orientation in and of itself that leads to these higher rates of mental health issues, but rather the experiences of oppression and marginalization and discrimination that really moderate that relationship. So what these disparities tell us is that this demographic really across the lifespan has a pretty substantial need for psychological services. And this is an issue because we have pretty poorly prepared professionals due in part to graduate mental health care programs that rarely address issues that are pertinent to trans or gender diverse children and their families. So often, even LGBT issues are not covered sufficiently, and trans issues are mentioned as an afterthought typically, if even at all. And so when there is a specific trans training component, since we don't have a consensus on what is the best way to treat these children, that it's usually not necessarily informed by the most recent data. And that we also have this issue of the training programs that do provide some trans information tends to be focused on adults, tends to be focused on trans individuals who have transitioned after puberty, and there's little to no mention of what to do with children. So other factors contributing to our poorly prepared professionals, we have very little attention paid by primary academic journals. We don't have very many educational resources available. We also really have a lack of formal training. So the training that exists, as I mentioned, tends to be outdated, or it could potentially cause harm. So we really need more clinics available to train kind of this next generation of providers who are able to provide affirming care. So I think it's also important to note that even really seasoned clinicians who are really competent can sometimes feel like they don't know what they're supposed to be doing when they have gender diverse kids who show up in their offices. So this lack of training and preparation can lead providers to provide a lot of inconsistent care at best and harmful care at worst. So this is a map of conversion therapy bans by state. I don't know if you can really read that, but basically the blue states, and there are a whopping 12 of them, have banned conversion therapy for minors. The green states are the ones who are working on passing legislation, but my pessimistic lens tells me that not all of those are going to pass. And basically in any state, even where it is banned, that religious leaders are actually still allowed to engage in conversion therapy, even under the states where it's not legal. California passed in 2012, go California. But again, it's a pretty small number when you think about it. So again, as I've been saying all along, there's really no expert consensus that exists on the treatment of trans and gender diverse children. And this is really particularly problematic because, as I've also mentioned, that research shows that social support and just the general support of children actually is really correlated with increased mental health outcomes for children. So partially due to the controversy on how to best treat these children, 3 main models are really available. So the first one being behavioral modification of gender nonconforming behavior, and this is at best just active discouragement, but also can include conversion therapy that I just mentioned. The wait and see model, which really emerged from the Dutch data that I talked about earlier. And then we have this somewhat newer but gender affirmative approach that really facilitates family acceptance, supports exploration of identities, and supports fully reversible interventions when appropriate. And I'd also just like to mention when I'm talking about interventions and approaches to care here, none of these approaches are endorsing medical intervention for young, so nobody's like trying to give a 5-year-old hormones or anything. But basically, anybody would say that anything that is medical intervention would happen in adolescence, but there are other interventions that we can offer to young children to help affirm their gender. So a handful of professional organizations have started to craft guidelines and standards to help providers with trans and gender diverse kids, but the main drawback being that these are really meant for adults. So some of them might be able to be applied to children and adolescents, but in general, these guidelines, when they were written, had adults in mind. So this is an example of the first one. Psychologists understand that gender is a non-binary construct that allows for a range of gender identities and that a person's gender identity may not align with sex assigned at birth. So like fairly basic. The American Counseling Association similarly in 2009 released their 8 best practices. This is a very not concise version of what we just read from APA, so I'm not going to read that. We also have the Association for Social Workers, who released a policy statement. This was actually more just like a call for trans affirmative professional development, legal work, and public advocacy. Very recently, actually earlier this week, I heard that the American Academy of Pediatrics will be releasing a policy statement coming out next month. And we actually also have a policy here at UCLA for gender-sensitive care that everybody is supposed to be aware of, that I think a lot of people are not. So then getting to WPATH, so this again is the World Professional Association for Transgender Health. It's like our biggest professional organization when it comes to transgender issues. In 2011, they released a pretty comprehensive document of their standards of care. This included information about children, and this is probably our most specific assessment and treatment standards that we have available. And then we also have the gender affirmative model, and this has specific guidance on treating gender diverse youth, particularly for young children. So I'm going to go in now, finally, to talk a little bit more about what the gender affirmative model is. I've been alluding to it all morning. So basically, from this model, the definition of gender health is the opportunity for a child to live in the gender that feels most real and or comfortable for the child, and the ability for children to express gender without experiencing restriction, criticism, or ostracism. And so some of the basic tenets of this are, first being that no gender identity or expression is pathological, that gender variations are not disorders, that gender presentations are diverse, they vary across cultures, so this also requires our own cultural sensitivity and humility as providers, that there are really infinite expressions of gender, that gender involves an integration of biology, development, socialization, culture, context, all of those good things I was talking about earlier, and that a person's gender might be fluid, it might be binary, it might be multiple, both at a particular time and point, and if and when it changes with an individual over time. And then finally, the last point, which refers to the minority stress that I already talked about, that pathology present is more often caused by cultural reactions to gender and gender identity than internal psychological disturbances within a child. So providers operating from the gender affirmative model practice under these particular guidelines. So first, we as care providers need to be able to evaluate and reevaluate our own social constructs and understanding of gender and sexuality within our cultural context, and how we might impose those positions on the children that we work with. That we as care providers see gender identity and expression as a basic human right, and that we remain open to changes over time. And this is really done by just listening closely to the children that we work with in their best attempts to explain to us what their identities are and then to respond to them in an affirming way. And also, as there isn't really any way to truly know with 100% certainty what the gender or sexuality of a child will be when they reach adulthood, we really need to work on managing feelings of not knowing. And this is also in order to assist parents in coping with not knowing. We also need to make use of the countertransference that we have to manage our own biases and assumptions and values about gender. And then finally, in a field that's constantly evolving and where we have a lot left to learn, we aim to increase our capacity to not know and to be really curious. So what does the gender affirmative model look like in everyday clinical practice? It isn't actually all that radical on the surface. In this model, co-occurring psychological issues among trans and gender diverse children are really handled in the following way. So first, distress that is identified being related to gender dysphoria is addressed first. And the reason for that being that we know that a lot of, basically what I just described for the minority stress model, is that a lot of distress, anxiety, depression may be related to the gender dysphoria. And so if we can address that first, then some of that may remit at least a little bit. Other symptomatic conditions then are going to be reevaluated and addressed next. It's really important in this model that parents are not pathologized. In the past, parents were typically blamed, or people would look at their parents to, ask what they did or didn't do to cause, quote unquote, cause their children to have a gender diverse identity. And then finally, if and when there is an identity or expression that might potentially be symbolic of something else, that there's further clinical investigation. And so this could happen, for example, you see sometimes as like a response to trauma, somebody trying to distance themselves, a flight from a perpetrator. I actually worked with one adolescent for over a year who was identifying as male due to what ended up being due to a long history of sexual assault and violence and re-victimization. And during that time, from an affirming model, I worked with her. She ended up identifying as female by the time we were done. But I used male pronouns. I used the male name that she chose. I helped her explore, information about what it would mean to transition beyond just a social transition. And then as we did trauma work over that year, she actually ended up not identifying as trans anymore and had a lot of insight into why she was identifying as male as a way to sort of protect herself from re-victimization. Not simple and straightforward. You see there are definitely situations where people are adopting a trans identity for reasons other than gender dysphoria. So it's really important to kind of keep that in mind and make sure that you're considering what those other considerations would be. I know I am running low on time. So here I just want to revisit kind of the concept of apples and oranges. So from our non-gender affirmative model approach, we're basically saying, and this is what we know from the early methodologically flawed research out of the Netherlands, that we can't determine a child's authentic gender early on. And even if we could, we might actually be damaging that child by boxing them into a corner too early if we facilitate a social transition or other affirming interventions too early. The gender affirmative approach really says that predictive variables are emerging to differentiate children who identify expression versus identity. These are our apples and our oranges, and that a small number of children really do emerge early who are persistent, consistent, and insistent. And that the risks of social transition are actually overblown. When we're talking about social transition here, we're talking about change in haircut, change in clothes, change in the name that somebody uses, maybe akin to another kid just choosing a nickname. These are things that can all be changed back fairly easily. And then actually there are higher risks of preventing a child from transitioning and living in their fully affirmed gender. So using the gender affirmative model in everyday practice also includes work supporting families. So for those of you who work with children and adolescents, you know that it's really important to include families in your work and that we can't treat children in a vacuum, even though we wish we could sometimes. So a multidimensional approach is really going to have the best outcomes, and that's one that considers the child's well-being, the family and relational support, and access to community resources as well. And we know, and since we know that family support is one of the biggest protective factors that's been identified in the literature, supporting families is really one of the best interventions that we can offer. So I already mentioned this study, but it's from the Trans Youth Project, which is a national longitudinal study that basically found that children between the ages of 3 and 12 who had socially transitioned with the support of their families had no disparities when it came to depression or anxiety, which again is pretty remarkable. So from the gender affirmative model, it's helpful to remember that families are kind of in a process that usually shifts over time. And in working with families, the goal is really to help families reach an increased level of attunement. So when a child expresses gender expansive identity or trans identity, it's pretty common for parents to feel a lot of difficult emotions, maybe anxiety or confusion or fear. And the idea is to shift to attunement, which is going beyond the idea of tolerance and going beyond the idea of acceptance, but actually getting to a place where you're really understanding and at harmony with the child's gender identity. And this model really encourages transparency. So this involves communicating to the parents that in sessions with a child, you'll be using the name and pronouns that the child wishes. If the parents are concerned with, the clinician encouraging their gender identity in some way, you could offer to meet with just the parents, since we know that the majority of the bulk of the work, most bang for our buck, is with parents. You could offer to meet with them alone until you build enough trust and rapport in order to start meeting with the child. It's also just really important to meet parents where they're at. So for example, if parents are not able to tolerate you as the provider using the child's chosen name, you could shift your language to use, your child, or using gender neutral pronouns instead of like using a name at all. And really the goal here being to get to a place where you can hold joint parent-child sessions where the parents learn how to really incorporate the child's gender identity into the family narrative. So this approach can be a really great psychoeducational opportunity. There's like so much bad information out there. Processing sort of parents' fear and loss is an important key. Listening to parents' current beliefs and feelings is really important. This might include, like I mentioned, feelings of grief or fear. And I think it's important to really try to hold their struggle and validate their struggle. And even if it's something that you're not necessarily agreeing with of what their point of view is. And then, really just utilizing therapeutic timing to gently encourage parents to kind of expand their ideas about gender. And to move towards attunement, we really help parents learn to listen to their child. This sounds really basic, but children are trying to communicate to us about their authentic gender identity. And so the cornerstone of healthy gender identity development is really being able to get parents to listen, particularly maybe when they don't want to. There's also room for working with siblings in this model when appropriate. And then finally, most affirming providers will usually recommend some sort of connection to community who share similar experiences, because we know that that can be really important. So even in the most affirming families, minority stress is still going to have an impact on youth. And so since many children and families are likely to experience significant adversity, the ability to foster resilience, both at the individual level and at the family level, is a really important component of successful outcomes for these kids. And so these are some of the factors that we know have been identified in fostering resilience. So supportive relationships, a sense of identity, experiences of power and control, cultural adherence, which fosters community connection, social cohesion. And so at the individual level, resilience can really be fostered by improving self-efficacy, coping skills, health-promoting behavior, social skills. For trans youth in particular, it's really important for defining and describing their own identities as another factor of resilience. And then at the family level, we have positive parent-child attachment and warmth, family cohesion, engagement, and support. And so in line with this research on resilience, we're currently developing a resilience building intervention here at UCLA, and this really just aims to improve a lot of those bullet points that I just talked about on the previous slide around coping skills and self-care and healthy and supportive relationships. So we ran a small pilot study last fall with some pretty promising mental health outcomes, and we are starting another pilot in a couple of weeks. So if you have any teens that you think would be a good fit, here's my plug to send them our way. We're going to start on October 3rd with hopefully starting another group up in January. And this is part of our sort of like larger Empower program that we've recently launched here, which is our comprehensive mental health program. And this is, a really important program that we have here as filling this need for trying to bolster up the training, the lack of training, if you will, that we have in our field currently to try to really train our next generation of affirmative providers. This is just a list of a couple of books. I have most of these up here if you want to look at any of them. But basically the top two, the Gender Affirmative Model and the Gender Creative Child, are from the same group of folks. Stephanie Brill's Transgender Teen and Transgender Child are really good resources, particularly to give to parents. They're really easy reads. The quick, easy guide to they, them pronouns. We didn't talk a lot about kind of more gender neutral identities and gender neutral pronouns, but this is kind of a cute book that is good for both providers and families alike. That's kind of written in like a comic book-like fashion. Trans Bodies, Trans Selves is a really cool, almost like encyclopedia-like book that has pretty much every topic that you could think of. And the Gender Quest workbook is a pretty good book, particularly for teens and young adults, that you can incorporate into your clinical work. Has some suggestions for activities but that's probably less appropriate for young children. And so with that, I managed to finish in, wow, that was pretty good. So here's our flyer. Send us your kids who are LGBTQ, who might be appropriate for our resilience class. And thank you.
Thanks so much, Dr. Ollen. I know I have several questions, but I want to give the opportunity to have questions from the audience first.
Hi, thank you so much. That was really interesting and also packed full of information. So, I think that you're really focused on a very important issue, which is providing support for kids and their families who are coming in maybe in distress or wanting support or help. But it seems like there's sort of a wider cultural issue happening here too, just in the way we think about gender and talk about gender and teach kids about gender in our culture. That's making life very challenging for these kids. And I'm wondering if you have recommendations for parents, for example, who have maybe more gender conforming kids, or their kids aren't yet gender non-conforming, just sort of how to talk to young kids about gender and gender related things that would kind of help make our society more accepting for these kids.
Yeah, thanks. That's a good question. I almost included a list of like children's books that are about kind of like gender diversity. And I think that is actually a great place to start. We use bibliotherapy with kids a lot. There are a handful of good books that I would happily share if you want to email me that kind of show gender identity and kind of like the spectrum of gender identity. And I think that even if you have cisgender kids, that's also really important because cisgender peers are going to be a huge factor of how these children, trans and gender diverse children, experience their day-to-day lives. So I would say using like bibliotherapy, sort of like parents just also offering maybe models of more broad gender roles and I would also say, policing children who are policing other children about gender. We see that a lot with little kids, especially, right? They're very concrete. And so they have, these ideas about what boys do and what girls do. And I think that gender roles, I think it's changing, right? I still think that gender, sort of like how we conceptualize gender roles as a culture is problematic. But I would say either through modeling, parents can, show sort of differences in gender roles. And I think that will help the context. I mean, it's not going to solve the problem, obviously, but I do think that might be one way to address it.
You mentioned that UCLA has a guidelines or policy on gender sensitive care. Where can folks find out about that?
That is on MedNet. So if you have MedNet access, it's under the policy section there. And that basically just includes information around like, we have the ability to put in, pronouns into Care Connect. My one aside about pronouns is that we usually say people's pronouns, not their preferred pronouns, because it's not what they prefer, it's what they use. So a lot of people still use preferred pronouns. Just a quick aside. So we can, so in Care Connect, we're able to put pronouns and names that people use as we would like a nickname for others. I know that some of the other policy in there is, around inpatient admissions that people are able to get housed or roomed with what is aligned with their gender identity, and that if there's like a difference between kind of what parents and the client say is the client's identity, they go with what the client says, not with what the family says. So there's a couple of really useful bullet points in there. If you haven't read it, I would suggest going and reading it. If you can't find it, email me and I can help you get in touch with it.
Thank you.
Sure.